Good afternoon, everyone, and thank you for joining us today. We are now at Module 7. We are almost done. 3 more modules to go. So today we are going to be doing health financing and health management. Alex, welcome. Thank you for joining us today. Alexandra is our French interpreter. So in case you need French interpretation, just click on the interpretation button at the bottom of your screen and choose French for your language. Otherwise,
Can you
sorry?
please set the channels? Mercy, I'm in the same room with you. Haven't been
I've
assigned
not set up. Oh, sorry. I thought I had. Interpreter. I'll just do that very fast. There we go. Do you have the channel, Alex? Oh, great. We can now start. So I'm going to introduce myself for anyone who is joining us for the first time. I'm Dr. Mercy Wanjala. I'm a family physician from Kenya and the Deputy Executive Coordinator for Afro-PHC. And I'd like to welcome you to our meeting today on health financing and financial management. So the Afro-PHC management course is a collaboration between Afro-PHC and AMREF, where AMREF is providing and hosting the leadership management and governance for health system strengthening course. And we are helping to bring people together for discussion and also to just build up in terms of capacity and build each other up and create a community of practice of primary healthcare workers who are empowered in terms of leadership and management. So let me just share my screen. For those who are continuing with the course, please do go on. I know it's not easy. It's a very detailed and intensive course. For those who are finished, congratulations. For those who are still doing it, keep on keeping on. Hopefully we will have a graduation in either December or January, and you will be one of those who are graduating. I don't know, I'm seeing as if my video keeps freezing. Let me just turn off video to improve quality. Can you hear me clearly? I'd seen someone had texted that the network is cracking, so probably I'm not very audible. Please just respond and let me know if I'm audible or if my sound is breaking before we continue. Oh, great. Thank you, Alex. So we'll continue today. Today we'll have a bit of a different setup. Normally we have a short presentation, then a question and answer session, and then we discuss a case. But today I'd like to have an ongoing discussion as we go through the various facets of healthcare financing and financial management, because I feel this is a module and a topic that gives people a lot of problems to understand what is health financing, what is it all about, how does it relate to universal health coverage, and how do I apply it in my setting? So I'm hoping we'll have an interactive class. So please try and engage as much as possible so that we can go and understand the concepts together and see how it can be applied in our setup. So the module had four units. The first one was on the concept of health financing and financial management. Then we moved on to health financing policy framework and mechanisms, then financial management, and finally expenditure tracking and reporting. But for the bulk of today and for the purpose of this meeting today, I'd like us to focus a lot on the health financing part, because it's what affects us most, especially as frontline primary healthcare workers. By the end of this module, we hope that everyone will be able to define the role and concepts of health financing and financial management in the context of universal health coverage, describe different functions of health financing policy and how policy decisions can influence progress towards UHC, apply financial management principles and tools for optimizing the allocation and efficient use of limited resources. That's especially for those of us who are health facility managers. And finally, analyze health expenditure data for evidence-based planning and accountability in health program and health facility settings. So I'll first of all take us through health financing and universal coverage. How are the two related? So first of all, WHO defines health financing as a core function of health systems that enables progress towards universal health coverage by improving effective service coverage and financial protection. So the main words here are universal health coverage and effective service coverage and financial protection. So the three main functions within healthcare financing that provide universal health coverage and financial protection are one, revenue collection, pooling, and purchasing. So for those of you who have interacted a lot with data on and papers written on universal health coverage and even courses on universal health coverage, you must have seen this cube. How many have interacted with this cube? By a show of hands. Anybody? Okay, so in terms of universal health coverage, and not to simplify, but to help people understand what universal health coverage is all about, various authors have come up with this cube, and you can see different versions of this cube trying to explain what universal health coverage is about. So you can see on your x-axis, it's all about population. That's the population who is covered. So if you have a collected pool of funds from wherever you're going to get it with the revenue collection function and pooling functions, so who are you going to cover in terms of who are you going to purchase services for? And then now in terms of assessing universal health coverage, the population that you have covered gives you a sense of how far you've gone in terms of achieving universal health coverage. Then you go to your y-axis. Y-axis looks at what services are going to be covered. That's the design of the package that you have that you're going, these are the services I'm going to pay for. Because remember, we do not have an unlimited source of funds and what we call the physical space. For most countries, especially low and middle income countries, we have what is called a limited physical space. In fact, for most of us most of our countries have not even achieved the bare minimum of 4 to 5% of the total financial expenditure or government expenditure should be for healthcare. A lot of us are still at around 2%, 3%, not even going anywhere near the Abuja Declaration recommendation of 15%. So you see that tells us we have limited resources, so we have to be smart about how we use them. So we have to choose who is covered. Ideally, we should cover everybody. Then what services can we cover? If we're covering everybody, that means we cannot be able to cover all the services. So we have to select which are those essential services which people cannot and should not do without that we are going to cover. Then that is the z-axis. Then moving on to your y-axis is a matter of now reducing cost sharing and fees. So this is where we come to the dimension of catastrophic health expenditure. So we want people to not pay out of pocket, that is one, or pay very little out of pocket. And most of the funds should come from our current pooled funds. And as you can see, that's a cartoon I found from a competition that was set up on who will make the best cartoon on moving towards universal healthcare coverage. So I don't know how many have played with the Rubik's Cube. Sometimes it can be fun, then sometimes it can get frustrating, especially when you're getting near the end and you cannot match anything. So our universal healthcare coverage cube is like a Rubik's Cube. And we are always playing around with it to see if we can meet all the dimension of the X, Y, Z axis. But it's quite difficult from the explanation that I've given you before because we have a limited physical space. So moving on to how universal healthcare financing and universal healthcare coverage ties in together. The functions of healthcare financing are supposed to provide people with quality, efficient care, and eventually improve the quality of life for people, make sure people get care when they need it. So in terms of the functions, we have intermediate objectives, and we have what we call outcomes of why are we doing health financing? Why are we pursuing universal healthcare coverage? So in raising revenue and pooling and purchasing, what we want to do is be able to cover for a certain number of or a certain package of healthcare benefits. And in covering for those healthcare benefits, we want there to be equity in resource distribution. And remember here, I'm saying equity and not equality, because equity means I meet someone where they are. And with equity, you'll find that there are people who need more resources than others. That is not equality. Equality is treating all the people the same, but we can't treat all people the same. For example, someone who lives on $1 a day and someone who is earning $75,000 a year, they cannot be treated equally. Because if this person earning $1 a day even spends 20 cents, that's 20 cents over a dollar to pay for consultation fee at a healthcare center, they might end up not eating that day. While if the person earning $75,000 a year does the same, they'll feel nothing. So equity is a very important intermediate objective. Efficiency, how well do we use the resources that we've been given? How well do we allocate those resources? Do we check for cost effectiveness of the services that we are buying, of the quality, of the feasibility of paying for a service? So that all comes down to efficiency. Then finally, transparency and accountability, which is very important because, like we said, we have limited fiscal space. So the money that we manage to collect, there has to be a transparent way of using that money, such that we are saying this money is going to cover maternal health care services, and everybody in the country or everyone who is involved in that pool or participating in that pool knows what is happening, and they get reports on what is happening in terms of efficiency and in terms of equity. Then finally, the objective of universal health coverage, health financing, is utilization relative to need, making sure we provide quality services, and universal financial protection. That means nobody goes into poverty because of paying for healthcare services. So this was a question that I pulled from the module, and I was hoping we could discuss with it a bit, having looked at health financing, universal health coverage, and what it is about, and having talked a bit about government health expenditure, how much governments should spend on healthcare financing. So this is a graph showing how much people are spending in terms of for inpatient services and outpatient services. So this is per capita government health spending across the region. This is from 2007. So let's look at it and see. So that's on the y-axis, we have the per capita health expenditure, and then on the x-axis we have the kind of services that they are paying for. So based on this, and based on the objectives that we have looked at in terms of equity, efficiency, let me just go back to it a bit. So in terms of these intermediate objectives, equity in resource distribution, efficiency, transparency, and accountability. So in terms of those three, in this, looking at this graph, what would you say, which objective would you say is not being achieved? Anyone, please feel free to raise your hand. Or should I call out somebody that I know? Anyone? Which objective is Tajikistan not achieving? Which intermediate objective? Benjamin? Beth? Christine? Oh, there's someone who's speaking. Go ahead.
Oh, I think it's the outpatient services.
What about the outpatient services?
I think, as you can see, the numbers are not as satisfactory as the rest of
Yes,
the
very
graphs. So I think achievement in the outpatient services is a bit low.
Very good. So now in terms of objectives, let's go back and look at this. In terms of objectives, the intermediate objectives, that's equity in resource distribution, efficiency, and transparency and accountability. Which one are they not achieving? Which objective?
I think it will be equity in resource distribution.
Excellent. Yeah, at least now I know I was not talking to myself. Thank you very much. Yeah, so equity in resource distribution is not being achieved. And going back to our graph, what you realize is they're paying more per capita for inpatient services than outpatient services. And another question, most patients who require outpatient services, where do they go? Which kind of facilities? Anyone? Go ahead, Mungabo.
So they usually use primary healthcare. So district hospitals, community health centers is where most people go for primary healthcare.
Excellent. So that means per capita, the government is spending less on primary healthcare services than other services. So I'm glad now we are beginning to see and analyze and dig into some of the data that's presented to us. So if the government is spending less per capita for primary healthcare services, that means there's inequity in resource distribution. And that means primary healthcare services and primary healthcare systems are going to suffer in terms of financing. Great. Let's move on. So this is just another diagram to show us the relationship between healthcare financing, how the different facets interact. It's the same as the other one that we have looked at, but only with a few additions on the intermediate objectives. So the whole idea behind health financing is financial protection. Financial protection from what? Catastrophic health expenditure. I know we've heard this term a lot. So what is catastrophic health expenditure? So Zhu and James looked at this and defined it in two dimensions. One, if a household, if the financial contributions to health equal to or exceed 40% of non-food expenditure, that is catastrophic health expenditure. So in terms of a percentage, if you go normally, I don't know how many of you are familiar with the community healthcare structure in your countries, but in Kenya, we have the community mapping tool. And part of the community mapping tool ideally should have a place for household income or household income and household expenditure. So once you get that data from a household, then you look at the expenditure in terms of health, and it exceeds 40%, that family is undergoing catastrophic healthcare expenditure and they do not have financial protection in terms of healthcare. Then if the household's capacity to pay, that is the income that remains after basic subsistence needs have been met, is low, that also means they are going into catastrophic healthcare expenditure. And that is what universal health coverage, health financing is all about. The objective is to make sure nobody becomes poor, or nobody is unable to cater for other needs other than food because they had to pay for healthcare. So as we go through the various functions of health financing, let's have that at the back of our mind. So here we have arrows showing us on this diagram, we have arrows showing us the different relationships of the intermediate objectives and the health system goals of healthcare financing. So you see the health system function of the health system function we are looking at here today is healthcare financing. Healthcare financing is about generating resources, stewardship, and also service delivery. So once you collect all that, you're supposed to be able to identify the correct services and the people who need those services and be able to purchase those services. And purchasing those services, in purchasing those services, you have to consider equity. That is the service use relative to need. You have to do a needs-based assessment of your population and community so that you don't pay for something that one person needs but 99 people don't need. That now comes down to efficiency. Then you also have to pay for quality, and you also have to ensure there's transparency and accountability in the stewardship of those resources. Function number one, revenue collection. There are so many ways in which we collect revenue for healthcare. One of them is direct taxes. Direct taxes is just whereby what the citizens in a country pay directly to the government, and it comes in various forms. So depending on your country's tax structure, there are so many things you pay, maybe rental income tax, your own income tax, etc. Then we have indirect taxes. So when it comes to indirect taxes, these are now the taxes like VAT, etc. that you pay indirectly. You don't pay it directly to the government. It is put on a product or on a service. So that's why you see sometimes on your receipt, inclusive of tax or not inclusive of tax. So that's an indirect tax. And another way of collecting resources using indirect tax is what we call sin tax, or taxes that are levied on products that would otherwise cause poor health. So they disincentivize people from using those products. An example is putting tax on cigarettes, putting tax on sugary products like soda and Coca-Cola products and such. So that's another way indirect taxes are collected to be used for financing health. Then we also have non-tax revenue. For example, revenue that you earn from exports. Then we have external grants. I'm sure we are all familiar with a lot of grants that come from the World Bank, from UNICEF and other organizations. Then we have external loans, like the ones we get from the Chinese government, amongst other governments, to develop different facets of the healthcare system. We have out-of-pocket payments, which are private. So those ones are the ones now that come directly from people and they pay directly for a healthcare service. Then we have contributions to voluntary health insurance and contributions to compulsory health insurance. So I don't want to go too much into the details, but I just wanted us to understand how money is collected for the purpose of health financing. So the thing about all these ways of collecting money for revenue for health financing is that there are things like direct and indirect taxes and non-tax revenue, which are difficult to control unless you have decided to ring-fence specific funds for health. For example, you can say everything that comes from cigarette tax, sugar tax, etc. goes to health. If you don't do that, then it will just be collected, but not go to healthcare. So that's why you see a lot of low and middle income countries struggling in terms of the fiscal space for health, because as much as they might have these ways of collecting revenue, this revenue is not ring-fenced for healthcare. It just goes to a general national revenue collection pool or basket or pocket, and then from there, every other sector, including the healthcare sector, now struggles to get those facilities. I wonder if anyone can raise a hand, name for me your country, and tell me how your country collects revenue for healthcare. Anyone? Remember, we want these things to be as practical as possible. So if someone today asks you anything about health financing within your country, you're able to explain to them very well. I can see a hand. Rose, go ahead, please. Introduce yourself, your country, and then...
I'm Rose Gahia, I'm from Rwanda.
Oh,
Thanks
great.
very much for this topic. It's very nice and very insightful. I think in our country we have, let me start on the bottom because I know it better. There is a compulsory contribution to compulsory health insurance because we have community health insurance, which is compulsory for all Rwandese. Every Rwandese has to have that community health insurance in Rwanda. And I think now we are at around 94, 98, something like that. Of everyone
98% participation.
Yeah, there is a participation, and the government participates and individual participates. Because we are classified into social classes. There is class 1, class 2, class 3, and class 4. And they pay differently. Class 1, the government pays for them, the insurance, the health insurance. And then class 2 pays 3,000 per year, class 3 and 4 pay 7,000 per year per person. So if you have a family of 7, multiply by 7,000, and then you pay that per year. But of course, the big contribution is of the government, but that's compulsory per household.
Okay.
So there is also voluntary contribution to voluntary health insurance because, for example, if I go to a private, that is voluntary. I'm not by anybody. It's not compulsory, but I have to go there myself. So most of some Rwandan who are well-to-do, they go to private insurances which are in the country. And those private insurance, there is a percentage which they pay for the health, they pay to the government health insurance pooling. I know we are going back to the pooling in front where there is a pooling. But that money, every private insurance has some percentage they pay to the government in that pooling of community health insurance. So if I pay like 10,000 in a private clinic, they add, I think, 18% or 16%, which will go to the government for supporting the community health insurance.
Okay.
Of course, there's out of pockets. Out of pockets also, there is if you go for insurance, there is insurance which does not cover the whole of it. For example, you cover like the government covers like 85 and you cover like 15, or you cover like the government covers like 90 and you covers 10. So there is also out of pockets, which is there. Of course, there is external loans, which comes, of course, and they put into the insurance. There is grants, which comes, and all the taxes. There is some money which goes into the health insurance and health system. And that's why we have gone, I think, out of 15% the budget declaration. But we are, I think, above 15%. So I think that's what I know in Rwanda.
Oh, great. Thank you so much for sharing, Rose. I think that's very important. And it's very impressive that Rwanda has achieved 98% participation in community health insurance, because it's something that a lot of countries have been trying to do. And we are glad that we can hear from and learn from Rwanda as well. So thank you so much for sharing. Anybody else? Mungabo?
Hello, I'm Mungabo from Zambia. For us, I think it's a melange similar to Rwanda. Traditionally, we had a non-tax revenue. I think that's what I'm going to call it. The government would just, on a monthly basis, dish out grants to various hospitals based on their catchment population and the services that they offered. And so they'd pull this money from just revenue that they get from everywhere. But then over the last 3 years or so, 3-4 years, we introduced a national health insurance scheme, which is more like a social health scheme. At present, people who are employed get a deduction from their salaries, and the government meets that. It's about 1% of your gross pay. For people who are unemployed, for those who are under 5 and above 65, they get the same services for free minus a contribution. Then everyone else who isn't employed, or their company, they're in the private sector and the company doesn't contribute towards, or they're between 5 and 65, they have to usually pay out of pocket, or there's an option to opt into the same national health insurance plan and pay like a monthly fee, which is not ridiculous. Yeah, then we also get a lot of external grants, but these are usually disease specific. So for the Global Fund, there'll be funds for malaria, TB, HIV, PEPFAR, mostly for HIV and such things.
Oh, great. Thank you so much for sharing that, Mugabo. It's interesting how the government is incentivizing people to join the National Health Insurance Plan by paying, it's almost like a co-financing. If your employer pays this, we also pay this. So I think that is also an interesting mix of revenue collection. Thank you so much for sharing.
Thank you.
Let me check if there's any other hand. No, so we can now, I think now we have understood a bit more about revenue collection and revenue collection mechanisms, including in our own country. I see El Hadi.
Good time. Thank you for the information and for facilitation of these modules. Actually, I am El Hadi from Sudan. Actually, the health system in Sudan, it is governmental and private. Besides health insurance is there also. There is also direct taxes and also indirect taxes, and with very limited external grant and loan, and also there is pocket payment from the patient himself, because we are suffering a lot from being away from the international community and grant, and this is reflected clearly on the weak health system and post-conflict health system management. Thank you. That is all.
Thank you so much for sharing, El Hadi. I think that is important also to note, and I'm glad that you have noted that your country, people are paying a lot out of pocket. And that is actually one of the measures of checking how much your country has done in terms of universal health coverage. Because if out-of-pocket payments in terms of percentage of healthcare spending are high, then you have poor universal health coverage or low, because a lot of people might end up going into catastrophic healthcare expenditure. So once you note there's a lot of out-of-pocket payments, the next thing is to check how many people who are paying out of pocket are going into catastrophic healthcare expenditure. And it's also good to note how much in terms of external loans and grants your country is receiving for as healthcare revenue, because the higher you move up in terms of economic performance, the more they will reduce the grants. So if you're somewhere you're seated either as a policymaker or in a managerial position, that needs to be at the back of your mind. Like, for example, right now, Kenya has moved from a low middle income country to a middle income country. So that means that our grants are going to dry up, because they're saying, hey, you guys are richer than you used to be, you have more money. That means your physical space, that's the flexibility of a government in determining where to spend revenue, is a bit larger than it used to be. So you don't need as much grant or external support from high-income countries as you did before. So that's why it's important to know how your country is collecting revenue and the implications of this in terms of your physical space and also sustainability going forward. Because as the grants dry up, that means you have to find other ways of financing the services that used to be paid for using grants. So any questions around revenue collections or any more contribution in terms of revenue collection? Let me see if we have any hands. Okay, let's now move on to the next function, which is now pooling that Rose had mentioned earlier. So once you collect this money, and like I mentioned with indirect taxes, direct taxes and loans, sometimes unless it is specifically ring-fenced for health, then you have to develop a national health budget for health, go to the finance ministry and fight for resources. But now once you have pulled all this together from out-of-pocket payments, from everywhere else that you've gotten it, you've accumulated it. Now it's time to define your population. Who am I going to spend these resources on? And the reason why we pool resources instead of someone going and paying for services by themselves, or instead of a household going and taking money out of their pocket and paying themselves, is for risk sharing and risk distribution. And the thing about risk sharing and risk distribution is this. If you have a pool, then you have to decide what the mix of that pool is. And as you decide what the mix of the pool is, you also have to decide, do I want participation to be voluntary or mandatory? So you had Rose mention that they have both voluntary and mandatory, but the mandatory one, as you can see, has actually achieved more than the voluntary one, because now with the mandatory one, the government has to contribute for those who cannot. Employers also have to contribute or help out. So with mandatory, it will ensure everybody is covered. And with mandatory, what happens in a lot of countries is if you do not have insurance or insurance cover, then you do not get the service. So that is usually a push for people to get the insurance. Then in terms of voluntary, now that is the kind of pool where a lot of private insurances fall, where you pay when you want and you choose the package that you want. That's participation. So you have to ask yourself now, what are the advantages and disadvantages of voluntary versus mandatory participation? That's an important decision for a country to make, so that you can decide whether the pool will be big enough or enough for everybody. Because if you make it voluntary, what will happen is what is happening in the US right now. Young, healthy people don't want to pay for health insurance because they don't get sick anyway. That's their reasoning for a lot of millennials and Gen Zs. So what happens? The pool will be made up of elderly and aging population who are mostly sick and utilize services more. Then what happens? You overuse your resources and you don't have anything left in the pool. That is why it's important to decide, do I want voluntary or do I want mandatory? Next thing you need to decide is the risk mix. In this pool that I want, who do I want in this pool? What is their age? What is their health status? What is their utilization rate? So you have to consider a lot of data and also a lot of factors as you're doing the risk mix. Like I've mentioned, if you have a mix where you have extremes of ages, under 5 over 60s, utilization rate is very high. So that means your pool will be constantly used and you will not have enough resources. So you have to make sure you don't have extremes of ages, for instance, in your pool. Then the other thing you have to think about when you're pooling resources and you're thinking about the population who is going to be covered by these services is the size. Do I want a very large pool with a good risk mix, that is different ages, different health status, or do I want a pool, for instance, that is small and caters to a specific population? Like I know a number of countries have the National Health Insurance Plan, but with a fragmented pooling system where you have a fund for civil servants, they pay different and they have a different service package. Then you have for the employed, then you have for probably I'm trying to remember the name, because I know that name from with Kiswahili, but with the English name escapes me. Jua Kali workers, or workers who work and are paid per day or per service. So they also have their own pool. So you have to think about what kind of pool you want in terms of even size, and whether you want a small pool, a large pool. Do you want a large pool which is also fragmented, like the NHIF that we have in Kenya? It's a large pool, but fragmented. And you have to think about what the advantages and the disadvantages of that. Any questions or examples in terms of pooling and what pooling looks like in your country and challenges that you're having in terms of pooling? Let's see if we have any raised hands. Rose, please go ahead.
Yeah, when you're talking about American young people not wanting to pay for their insurance, is it voluntary or mandatory?
In fact, it is.
Because why I'm saying so is that in Rwanda, the mandatory one, you can't get any service when you don't pay for the whole family. For example, you are a family of 5 and you pay for 3. That you can't get even if you are paid for 1 or 2 or 3. So it becomes so mandatory that every person in that family, because like insurance or pooling is not like you are not falling sick and another one is falling sick. It's helping each other. That's why you call it community health insurance. It's mutual. So it's like we are putting in one basket whether I fall sick or not falling sick. So I don't know how in America, even if you're falling sick or not falling sick, you're not helping those one who are not. And that's the essence of an insurance, by the way. It's helping.
It is actually, so that when, and we are all getting there anyway at some point.
Yes, so I was wondering why in America it's not being done like that. Second, as you said, in the
Sorry, Rose, I don't know if it's just me, I can't hear you.
I said also the last part of the fragmented one. I think even in our country we have a fragmented one, and you know, the government and workers have their own health insurance scheme. Then the general population, because of cost is the biggest, have their own, and the package of service are different, and that's what we are now fighting for as people who are fighting. I work for, I'm the vice chair of our national Rwanda National NCD Alliance. So we are looking at the packages of what they are giving those of the community health-based insurance and how much they can add on, because those the government, which we call like Lama or whatever, they get a big services better than those which they get from the community health insurance. So it's still also there, and it's work in the process. I think we are doing it, and it's a gap which has been seen. And I think most of the countries, that's where they start, because there is one for the YAME, there is one for the government employees, there is one for whatever. So you find that even the services are not the same, even the package is not the same. But of course, even the amount of money paid is not the same. So we have to look at all those.
Yes. Thank you so much for sharing, Rose. I think that is a journey, and like you said, work in progress for a lot of countries, figuring out what do we do with our pool and how do we design it such that we maintain equity. Like we said, equity in terms of distributing the resources, and also equity in terms of sharing what is in the pool. Because like you said, some are paying differently, so they get different services and different packages. Some, what they need is different from others. Because, for example, I'll give an example of something I learned from Ireland, and the kind, it was Holland, and the kind of health insurance that they have. If, for instance, I have a problem with my teeth, I can actually go and choose and say, for me, give me this package, right? But do not cover me for dental insurance. So I pay extra for dental insurance as well. And then if I wear glasses, or if I don't wear glasses, and the package is covering for glasses, which I don't need, but I need dental, then at the end of the day, I say pay for dental, don't pay for glasses. So there's a lot of there's a lot that goes on in there that people are trying to figure out, how do I cover people according to their needs? That is the equity dimension. And like the Rubik's cubes that we saw earlier, it is not easy to match those. I had seen another hand, if I'm not wrong. Yeah, I can see some more hands. Let me just check who it is. I will have Rael. Rael has not spoken, and then after Rael, we'll have Mungabo. Go ahead, Rael.
I'm Rael Akoru. I'm a public health officer by profession. This is my first time to attend this training. My question is, or my contribution is, I wonder as to how and why the American youth claim that they cannot pay and they don't get sick. But we have issues with adolescents. For example, girls, when they start their puberty stages, adolescent stages, menstruation comes with health challenges. How do youth want to cover themselves when it comes to issues, conditions as pertaining to menstruation? Thank you.
Thank you so much, Rael. And that was just an example of what can happen. Please, if you're not speaking, please mute. I don't know who's unmuted. Some background noise. Let me just check. Oh, thank you. So that was just an example of showing what could happen if you have voluntary rather than mandatory health insurance. So the health insurance premium in the US is a bit high because healthcare costs there are also high. And they have two systems. They have the Medicaid and Medicare. So depending on your age, you have Medicaid and Medicare, and there are things that Medicare covers that Medicaid doesn't. And then Medicaid, if you're over 60, you have to get Medicaid or something else. So that's kind of like the mix of what happens with the US insurance system. So that example I was giving is just an example of why we need to understand healthcare financing and what to do about the pools, because we are dealing with different people and even a different generation right now. Because the Gen Zs, because they have not grown in a social world, they have grown in a capitalist world, it is hard to make them think about socializing social services like healthcare and education. In fact, the moment you mention community social insurance, to them, they think you want to change the system from capitalist to socialist. So that's a bit of the capitalistic thinking. But when it comes to healthcare, which is a social or public good, then the best way is, as Rose mentioned, the social insurance systems. But then you also have to understand their thinking, because they're like, why should I pay high premiums for a healthcare system I might never use? Of course, that is short-sighted thinking, but in the moment, that's what they're thinking. And to be honest, a lot of people in a lot of our countries, if you ask them, they'll tell you the same thing. When it comes to insurance, people always think, why am I paying for something I'll never use? Even that's why some people go around without car insurance, because they're like, I drive safely. So if I drive safely, I'll never have an accident. Even if I have, so if I'll never have an accident, that's the wrong kind of thinking. But now the important thing, like you said, is for people to think about, what if I need it? And like you've mentioned, there's a lot of preventive care. There's a lot of adolescent health care that is required as well. That's why you will find for some pools, they cover people like the Kenyan NHIF. People are covered per household up to a certain age. So anyone who is an adolescent is covered under the parents' insurance to make sure that they're covered. And then we have levels of care like the primary health care. RM and CH services are free. But now the problem is the service is free, but you pay for the drugs in case the drugs are not available. So it's a complex system, and like you've mentioned, it's something that we need to think about. Mungabo, go ahead.
I like how you argued for why various generations might find paying into a common pool different. I think that's very important, like the anthropological aspect of what causes people to behave in a certain way. There is some Nobel laureate for economics, his name is right now, but he brought the similar argument about being socialist and how if you're more fortunate than other people, once in a while it is just fair for people to get a little bit more money from you and for you to make bigger contributions, especially into a pool such as like a health pool. Outside that, I think for the national health insurance policy in Zambia, for us, you don't have the luxury to nitpick. Everything, it's the same package.
Cynthia, please mute your mic.
Everyone
Thank
gets
you.
access to the same services. What I've noticed that is different, however, is if you are in the capital city, Lusaka, you get a whole lot more out of the health scheme because even private practices, private pharmacies, private physiotherapists, private optometrists also offer services based on the exact same national health social scheme. But if you're in a town further away, you'll find that maybe there's only a district hospital that can offer that covers that you can go to, and you find that you are limited to what medications are available to you, what services are available to you. But otherwise, the scheme is the same. So unless maybe one wants to travel when they get sick so that they can access more services from like a bigger town, but otherwise, that's the only disparity at present.
Thank you so much for that, Mungabo, because you've mentioned something very important. Again, the equity dimension, because now you've mentioned the rural-urban divide. Because if the services are only available at a capital city, but you've been told, oh, with this card, you can get this service, but this service is not available here, it's available in the city. That again becomes a problem, which moves me next to our next function, which is now purchasing. So we have collected the money, we have put it in a basket, and now we are trying to decide, these people who have put money in our basket, they want something in return for that money. So now we have to decide, what are we going to give these people in return for what they give, the money they have given us? And to do that, we have to go to the healthcare providers to give us something to exchange for that money that is in this pool and give these people value for money. So purchasing now is allocation of the funds we've collected in our pool to different providers so that they can deliver different healthcare goods and services. And this can be a spectrum ranging all the way to promotion and preventive services to curative and rehabilitative services. So it's a spectrum. So it's just a matter of deciding what do we want to pay for. And in deciding what we want to pay for and how we are going to pay for it or how we are going to buy these services, there are two ways we can approach it. Either we can take a passive approach where we just give funds and say, oh, hospital number this, I'm going to give you $5,000 and I'm going to give you 500 people. So treat them. That is an example of a passive approach to purchasing or paying for services, where without using any information about need or performance, we just pay. That's one example. We can also take a different approach, which I'm sure you have heard a lot about, and you have heard about Spark Africa, that is championing strategic purchasing in African countries. So what is strategic purchasing? Strategic purchasing is making choices based on 1, population needs, 2, availability of effective medical intervention, which brings us to the point that Mungabo made on, is the service available in my town or do I have to go to another town? Relative cost effectiveness of interventions. Is this intervention cost effective or is it a waste of money? Utilization of services. how often do adolescents come to this clinic to ask for contraceptive or sex education, for instance? Quality and efficiency of services delivered by providers. Quality dimension is very key in health financing, because if I am buying services for people and they're not of quality, that means they're not safe, they're not timely, they're not efficient, they're not effective, they're not patient-centered, then you are not utilizing your funds well, and you have a problem with stewardship and accountability for the funds that people have put in your pool. So there are different mechanisms that we use to purchase these services. For example, fee for service. Fee for service means if I come and I say I want maybe dressing, for instance, someone comes and gets dressed, and then I will be billed as the one purchasing the service. Dressing, $5. That is fee for service. Capitation is the example that I gave you, where I go and tell a provider, listen, I have this population of 5,000 people, and I want you to cover them for services, but I'm going to pay you only $100 per month per person. So it is up to you to decide how you're going to utilize that $100 per person. And the problem with this is people might get their services underprovided, because I don't want to finish my money. You've given me $100. I want to make a profit, right? So I'm not going to spend the whole $100. So there are services which I'll decide I will not provide. Then the fee for service, the problem could be that people inflate services and over provide services. Like someone just comes in and says, my tooth is aching. They get an MRI, they get a CT scan, they get blood toxicology, you know, so that I can make more money for fee for service. Case-based means for every person who comes with hypertension, for instance, in your facility, I will pay this amount of money only. So I'm not paying for a service. I'm not paying for a procedure. I am paying for the case itself. Someone comes for malaria, whatever the diagnosis, treatment, etc. For any malaria case, this is the amount I'm paying. And then the other one is global budget, where it's just a matter of, this is the amount of money that we have. So now we purchase services. However, that's another way of passive purchasing. So in all this purchasing, we have incentives and disincentives. So incentives could be volume of services. And as we mentioned, for fee for service, one would want to increase volume, but for capitation, someone wants to decrease volume. Then use of input resources, pharmaceuticals, the admission rate, average length of stay. Because for capitation, I don't want you to stay in my hospital too long. You will use too much money. So I want you, after 24, 48 hours out. For fee for service, I want you to stay for a week, even if by the second day you are fine. Then also prevention of diseases and administrative costs now for providing these services. So those are things that you can use as incentives or disincentives depending on what you are buying. So these are some of, on the left, you can see still some of the purchasing mechanisms. You can see that salaries is also a purchasing mechanism, because remember, healthcare providers are providing a service. So if the government has employed you and they're paying you as a healthcare provider, that is a purchasing mechanism. So for example, for primary healthcare workers, and I give this example because in most of the countries, primary healthcare services, especially maternal and child health services, are usually provided free. And I put free in quotes because there's nothing that is free under the sun. Somebody has to pay for it. So the person who's coming there isn't paying for, because the government has already paid the person who's there. The government has already bought the drugs, and the government has already built the hospital. So somebody has paid. So it's not essentially a free service, but now the provider, the thing that you're getting is your salary. Then another way is payment for performance. That means maybe you agree, if you maybe that is payment for performance or results-based financing, is whereby we agree if you achieve these indicators or these targets, then we give you this amount for your next year. And if you increase your indicators or improve your indicators by this, then we increase your budget by 15% and such like. Then we have diagnostic related groups, which is almost the same as the case-based, where you are paid per diagnosis. Then we have per diems. We know we get a lot of per diems. If, for example, one of the things that I know you can get per diem for in terms of service delivery is if a nurse or a doctor or an anesthetist or someone transports a patient from one facility to the other outside of working hours, like for example, at night and such. Fee for service we've talked about. Vouchers. I know that like in Kenya, we have had a voucher system at some point for women where you're given a voucher and that voucher covers for you for antenatal care and delivery and postnatal care. And also there are some NGOs that finance health through vouchers. So you're given a voucher maybe for 5,000 or for 10,000 for your family. And whenever you go to that facility, they give you the services for free in quotes because someone else is paying, but for you it appears free. Then we have health equity funds, which is a good way of channeling the social assistance funds, like for what Rose mentioned, the people, for instance, who cannot pay at all, or what people call indigents. How do you channel those funds? So someone like the government decided to be paying for those people, then contracting in clinical services and also contracting outpatient services. So those are different ways in which we can purchase services. But remember, with all these mechanisms, still you have to think, am I doing passive purchasing or am I doing strategic purchasing? So in terms of purchasing relationships and strategic purchasing actions, we have to understand relationships between the person who is collecting the revenue, the person who is paying, the person who is receiving the money and giving the services. So for example, if the government happens to be the one collecting the funds, normally they advise that the person who is doing the revenue collection and pooling should not be the same person who is doing the purchasing. They should be separated for better transparency and accountability. So it is important for the government to have reporting mechanisms for their purchases so that if for example, the government decides to buy a certain package or a certain drug or pay for a certain service, there has to be a cost-benefit analysis that has been done. There has to be a quality analysis that has been done, and to ensure that this service that I'm purchasing will be cost-effective and it is of quality. So those are things that the government has to do in terms of stewardship, and also in terms of stewardship and accountability. The citizens, the people using the services, have to give feedback. That's why patient feedback forms and patient experience studies are very important, so that we can know these services that we are buying with this money, are they quality services? Are they cost effective? Are they equitable? That is an important thing for anyone who wants to do strategic purchasing. Then in terms of providers, it is important to have clear-cut contracts, that is one, clear-cut payment mechanisms and guidance in terms of the service provisions, and clear systems of monitoring performance and quality, so that you ensure that they deliver high quality service and a good mix that caters for people according to their need. So those are the different relationships and how to manage those relationships when you are purchasing. Questions or anyone who would like to share about a payment or purchasing mechanism that they are doing in their country, and whether they're doing strategic purchasing or passive purchasing? Let me see hands. Rose, go ahead.
To remain there, but I can say something. I think we are doing strategic purchasing because we are doing, first, there used to be payment for performance indicators, because the government would give like hospitals some indicators and then they buy those indicators. And I think it's still being done. And of course, also they look at the population needs. They say in such a province or such a district, what are the most needed or what are the most prevalence of the diseases in that area? And then they send man according to that area. But of course, that one starts at the district level, and because every level, we have high levels of health service for primary health care in Rwanda. We start with the community. There is purchasing at the community level, though they don't pay them, but they put them into cooperatives, and then they give them money to do some cooperatives so that they get incentives from that cooperative, because they are not paid salaries or they are not paid per diems. So that's the purchasing of what the community health workers are doing. Of course, they look also at the availability and effectiveness of medical intervention. And this is what we are doing now. I'm in the country committee of now devising the community health insurance. What intervention can it buy, adding to what they have already got? So if we say we look at the kidney dialysis, for example, is it cost effective? We do kidney transplant, and that's what we are now looking at. We are trying to do strategic purchasing now, looking at cons and pros of if we do this, would it be most cost effective? Would we have more patients on these services? So I think Rwanda is starting, though it used to do passive, but now it is going to strategic purchasing. I think also you have to see the utilization of the services, as you're saying. How are the services at the community level being used? How are the services? Because there is a package and there is the indicators, the performance indicators at this level. So in Rwanda, I think we are doing strategic purchasing. Thank you.
All right, thank you so much for sharing that, Rose. And there's something interesting you have mentioned in terms of how to compensate community health workers, which I find very interesting. And it is what we call, it's like a community empowerment strategy, because you said they put them in cooperatives and then they get money from that and then they start businesses. And I think that is a very smart way of compensating them without giving them like the direct money and incentives, such that they have something for their hands to do as well. So that is something I have learned today, which I find very interesting. So thank you for sharing. We'll have Okoyen and then Ryle.
Okay, can you hear me?
Yes, loud and clear.
Okay, great. It's been quite interesting on this discourse on healthcare financing, though I missed a bit of some things that I wanted to pick, like doing a physical space analysis and all that. Probably as the discussions go on, maybe I'll get to hear all that and get more knowledge. But sharing experience in terms of researching in, I'm in Nigeria, I'm in a state in Nigeria. What I noticed, what obtains around here is that there's a state health insurance agency. They do the collection. And then they're also doing the post-searching. So revenue collection being done and also buying of services also done. But it's those strategic post-searching that is being done. But they do the purchasing of services. Now, the point is that in Nigeria, we used to use HMOs. You know, it's the HMOs that you use for the National Health Insurance Scheme. Is the health maintenance organizations that they purchase on behalf of the insurance agency. But my state's own differed a little bit, where because of the issues of the HMOs, the challenges with the HMOs and all that, the agency decided to do the purchasing itself. So that is the dynamics. And you talked about the issues of accountability, where the person collecting is also doing the buying of services. And then there's some problem with accountability. But that seemed to be what is preferred here, as that works better. So these are the dynamics of what we have experienced here. But the other part of the challenges in terms of coverage is actually more of the formal sector, civil servants, government workers, who the collections are done from their salaries, the deduction.
Hello? Okoyen, I think we have lost you.
Oh, really?
Oh, yeah, you're back.
Okay. So I was saying that for the formal sector, the collection is easy because they are civil servants. The pool of who is there is more of civil servants, so they can easily collect. But for the informal sector, who is a larger part of the population, is difficult. They are not part. They are not really keyed into the scheme, because you are depending and waiting for them to be able to pay their premiums, and the means of getting premium from them, because it's not an organized sector, like unlike the civil servants, who you can have a source to make deductions straight. So right now, they seem not covered. So these are the bits of the difficulties that are around the dynamics of what is obtainable here. I said, let me share it. Thank you.
Thank you so much, Okoyen, for that. I don't know, Rose, could you share on what Rwanda is doing to cover people in the informal sector? Because you did mention that your community social insurance has actually gotten up to a participation rate of 98%. So probably that could help Okoyen as well.
Thank you.
Exactly, that's great. It will be good to hear that experience.
Thank you. What you have in Rwanda is what we call community health insurance. Community means that every household in Rwanda has to pay his family or her family insurance, medical insurance. And we have social categories of social standing. They put us in social standing, how you are according to your income. So there is income, the first level, the second level, and the third level. That is how social you are standing or your income. If you don't have any income, when they do like a census, they see don't have this and this and this and this, you're like this and this and this. There are some indicators and what the criteria which they follow. And they find that you don't have anything at all. You are put, and the village community put you in such a category of people, like in category 1. That means the government will pay for you the health insurance about, I think the government pays 90% because they don't want you to misuse the insurance. You have to pay like, you pay like 100 francs. 100 francs is very little money to show that at least you participate in your insurance. So 100 francs is like, I think like 0 pence or pound or whatever, a dollar. So just to encourage people not to misuse the insurance, you know how people misuse insurance. So the whole country, the mayors of the district, because we have a mayors, they put it into the contractual performance, which they sign with the president. That if I have such a population, if, for example, I have 20,000 people in my district, that's a household, and then they count that each household has at least 5 people. That's about 200 times 20. Then they will know that each person, they categorize them, and then they know those who are in the category 1, category 2, category 3, category 4. So those who pay for themselves have to pay the whole family. You can't be treated if you don't pay for the whole family. They know the head of the family, you pay it through nowadays we pay through on our mobile phones, every household. You use your ID and you use your voting number and your ID, and then you pay everything. Rwanda is a country that everybody has an information somewhere. So your phone and your ID, you pay for it, and then you get a reply, and you are in the system, and they know that you've already paid in the system. And when you go to a health center, you show that message and you are treated. So the whole country is covered because of that contractual performance, which mayor signs with the president, that my population will, all the population will be covered on health insurance. So that's how it becomes so easy. I don't know if I have explained it well.
Yes, Rose, you have. Thank you so much. Because now you have shown that you are using a community approach where you go by households and not an employment-based approach. An employment-based approach means I target people's earnings.
Yes.
But a community-based approach means I target families within a community. And I think that is a very good approach to ensure that everybody gets covered. Thank you so much, Rose.
Yes,
whether you're employed
or not employed, you are covered. Because if you're not employed, you don't have an income, the government will pay for you. But you are known that you are not working, you are not employed, you are not whatever. But those who are working, at least when you're writing, when you are filling in the form to get those categories, at least you say, I have a house of my own, I have 5 children who are working. There's something like that, that they look at a family, a household, nucleus, and looking at an individual. If my son is working, and I say where that son of yours is working, they expect that son to help you pay the insurance. The community one is not very expensive. For example, the highest category pays $7,000, which I mean in francs, which is like $7 per year. Yeah. You find that's very little money. So they have to look at the household, not an individual.
Then you
Thank
also
you
talked
so
about
much for
the
that,
contractual, the contractual agreement with, is it the county leadership? So the county leadership is judged based on the coverage that he or she is able to achieve in that county. There was a comment on that perspective that you mentioned.
In Rwanda, districts work on what we call imihigo. Imihigo is the contractual, what you will do in a year in your district, because you have mayors. So they will say we shall reach how many children are not malnutrition, how many women will access family planning, how many households will access community health insurance. So they have all those targets which they sign in front of the President of the Republic of Rwanda. So they have to make sure at the end of the year, there will be, there is an evaluation, and sometimes they were being graded who has done well, and and every now and then there is a flash report which goes on, showing how a district is doing in community health insurance, it's doing with their maternal and child, and doing with family planning, and doing with children enrollment and the school. So it's something that every mayor of a district signs in front of the president. So there is a transparency and equity.
Thank you so much, Rose, for that. I think you have brought in another dimension of healthcare financing, which is the stewardship component, whereby good leadership, good governance with accountability is key. Because by them signing those contracts, they are making themselves accountable. So I think that is a very important dimension. And I hope, Okoye, now you have been helped and you have some ideas on what you can do to solve the issues in Nigeria.
Thank you. Exactly. A lot of learning from here. Thank you.
Mungabo, you had something, is that an old hand or you have something to say?
I think I was just flabbergasted with Rose's account. I'm here thinking to myself, I'm like, are we in the same Africa?
Yes, you are.
We are in the same Africa. We have our president called Paul Kagame. So he's accountable and he makes everyone accountable to in any
Okay.
level of government they are in.
I was here Googling. I'm like, what is the population again? Is it 1 million? Is it like Botswana?
No, it is 13 million at the moment.
Okay. No, it is
Leadership
well.
can make a significant difference in anything you're doing. Like John C.
Clearly.
Maxwell said,
Clearly.
everything
But then-
rises and falls on leadership.
On leadership, indeed.
Yes.
But then you must have, at a community level, you must have invested quite a lot in just statistics and accumulation of data and your data systems, because don't people move, you know? And I don't know, maybe it's a Zambian thing, but then we have certain people who are just so difficult to access. Like, even if I've personally done surveys where you're trying to ask someone, elicit from them, how much do you earn per week, per month, per annum? And people are just unable to be helpful. So I'm just, yeah, again.
Mugabo, what we have here in Rwanda, we have leadership from what we call the village level. There is a village, there is what we call a city, there is what we call a sector, and there is what we call a district and a country. So
Yeah.
each level feeds another one as we go up. So like in my village, we have about 200 houses. So the head of that village will be responsible to see who is not paying the health insurance in my village. So it will be like people are going up and up from different, then they come together and they show who is doing well in a certain village. Sometimes they give even incentive of giving them like a prize that they have done well. So it's something like starts down at the community level in the village.
Okay. It's good to know.
Thank you so much, Rose, for volunteering to share your experiences and what you're doing, because I think a lot of people are learning from the discussions, although we're having 3 constant people discussing. So let me just read some things from the chat as well. We have Olalekan, who's talking about Nigeria, the Basic Healthcare Provision Fund being funded from an annual grant from the federal government of Nigeria of not less than 1% of the consolidated revenue fund, grants by international donor partners, funds from other resources inclusive of the private sector. Then the purposes are to provide a basic minimum package of health services in one selected health facility per political ward, strengthening the primary healthcare system for provision of essential drugs, vaccines and consumables, provision and maintenance of facilities, labs, equipment and transport for eligible primary healthcare facilities, also emergency medical treatment. And the beneficiaries are vulnerable people under 5, old people and pregnant women. And the service is free for all enrolled people. So I think that is now an example of how the fund specifically goes to cover people who cannot cover themselves or are vulnerable in terms of their health. And I think now we can move on to, I think I feel that we have adequately covered healthcare financing. And my hope is that if someone today calls you for a discussion and says, hey, tell me a little bit about health financing in your country, tell me about universal health coverage in your country, at least you have the basics of talking about it as well as analyzing it, because it is important to be able to analyze the data that we get. If you hear there's a World Bank report on Rwanda health financing, you can be able to look at it, look at catastrophic health expenditure, look at out-pocket payments, compare, look at if they're achieving objectives in terms of equity, quality, service delivery, accountability, transparency. So I'm hoping that at the end of this all, you can be able to look at a paper, look at a report, be able to analyze it, think about it where you're working right now, You know, how are the people who are coming to my facility, how are they paying for the services? Who is paying for them? And are they getting quality for the services that are being paid for? So those are things that we can now, I hope we can now think about. So the other component we need to deal with today is financial management, which to me, when you tell me financial management, I just think of fiscal responsibility and accountability. Who is responsible for money? Who is accountable for it? Then what are they supposed to be responsible for and accountable for? Then how are they supposed to be responsible and how do they maintain accountability? So I'm just going to brush through a few concepts on financial management, especially for those who are managing health facilities, because financial management can get a bit technical. If you've done accounting or a course in financial management, you know what I'm talking about, the whole issue of balancing books, what is an income statement, what is a loss and profit statement and such things. I'm not going to go into the nitty-gritties of that, just the management part and things you should know if someone has decided to make you an AIE holder. I don't know what they call them in your country, but in our country, they call you an AIE holder. As they've given you authority to incur expenditure. And that means you're responsible and accountable for any kind of resources and financial resources that come through that facility. And nothing comes through or goes out without your signature and such. So the principles are pretty basic and simple. And I like that we have an acronym called CAT Visa. Visa reminds you of money, the way you go around swiping a Visa. And the CAT, well, I don't know what to equate that to, but the Visa part is what got me in this acronym. So financial management is simply the process of achieving the organization's objective in an efficient manner through planning, which is budgeting, acquiring, organizing, directing, monitoring, controlling, and reporting. So that's just a simple definition of financial management. Even think about your own house. Once you get your income, what do you do with it? You sit down and you plan. You say, hey, this is going to rent, this will go into buying food, this will go into school fees, this will go into buying shoes and hair, such like things. And then from there, you plan how you're going to spend it. Am I going to be swiping? Do I need cash? Do I need mobile money? So you put it there. Then now you direct it. This one goes here. This one goes to school fees for child 1. This one goes to buying shoes for child 2 for term 2. And then now you start monitoring. Last month, I had a credit card debt or I had to borrow 5,000 extra. Why did I have to borrow 5,000 extra? Is there something that I could forego? For example, last month, I did my hair twice instead of once. So probably if I do my hair once, I'll have an extra 5,000 or an extra $50 to spend next month, or I won't have to borrow money, such like. And then controlling. How do I ensure that if I have set aside money for school fees, I don't go and use it for something else? Maybe I decide to separate accounts. That helps me. And then reporting. At the end of it all, if, for example, you are not the AIE holder in your house, you are a supporting structure. Now you might decide to report to the AIE holder, you gave me 50,000 this month. This is how I used it. So that is financial management in a simple way. So what are the important principles when it comes to financial management? 1, consistency. That means you should not have 1,000,001 variations, for example, in your budget. If your budget every month is 50,000, if next month it becomes 55,000, then you have to investigate, monitoring, why there's a variation, because consistency is key. Accountability, you need to be someone who is trustworthy and who can keep themselves and also other people under you or around you accountable. For example, you tell a child, no, stop running around with the school shoes in the field. I'm not going to be buying shoes every single school term. Then transparency, you have to be open and honest about your spending, about what you're spending for, etc. Viability, it has to be financially viable. You don't go for things that your budget cannot cover or which are not effective. Integrity for me, I usually just define it as doing the right thing at the right time, in the right manner, with the right people, etc. Just doing things right and aligning those right. That is integrity. Stewardship just means if someone gives you something to watch over, like I'm going to give a good example from the Bible where it says, if someone comes and gives you their goat or their property, and they tell you that watch this goat for me, then someone steals it, or the goat falls into a hole and dies, you have to replace that goat. That is good stewardship, because you have accepted ownership over someone else's resources. So you have to care for them as you would care for something that is your own. Accounting standards. They're international accounting standards. Those ones accountants would know better, and I don't want to go into details of that. So you have to make sure you maintain accounting standards, like drawing financial statements, having an audit report, such like things. Those are standards which are set there, and you have to abide by them. Then we have some building blocks and tools that we use in financial management. And one of them is financial planning, that is budgeting. You'll hear either the district health management team or the county or sub-county health management team saying, we want to see what you want to spend your money on this quarter or this year. Accounting records, those are now the books that you hear people talk about bookkeeping. That is keeping track. It's like tracking your expenditure, tracking what comes in, tracking what goes out. Financial organization, we'll talk about the tools for that. Monitoring and having internal controls to ensure that you maintain the principles of financial management and the accounting standards. Then other tools which are very important are financial policies and regulations. You have to know them for your country. Strategic plan. So because your financial planning has to go hand in hand with your strategic plan. If something is not in your strategic plan, then it should not show up on your budget. Business plan for those in private. You need to have a business plan, because that business plan is going to inform how much money you need. For example, for your private clinic, if you're setting up a private clinic, the business plan will inform how much money you need. So how much planning you need to do in terms of what is going to come in and what I'm going to need to spend, and then what I'm going to need to bring in to do what is called breaking even if you're in business, or to get a surplus if you're maybe a non-profit organization or a non-profit hospital or clinic. Then budgets. Work plans, because your strategic plan, your budget, and your work plan always have to align. So work plan basically details the activities you're going to do. So I have a strategic plan and I say, oh, maybe a strategic objective is to increase revenue. And the increasing revenue will have activities. So those activities are what now goes into your work plan. Cash flow forecast, just to say, in this next quarter or in this year, I expect to make this much money. And making that much money could be from the revenue sources we talked about earlier when you're talking about financing. It could be from grants. It could be from donations. It could be from loans. So that cash flow forecast, those are the things that go there. Then feasibility studies. Feasibility studies means I am setting up a clinic here, or there's already a clinic or a government facility. So I decide to set up a pediatric unit here. Feasibility study will tell me how many children live in this community. And if I get there's only 5 children, then I'm like, it's not feasible for me to set up a pediatric unit, because how will that pediatric unit pay for itself, or how will I recover money from that pediatric unit if there are no children? So that is what feasibility studies are for, and you should have that as you're setting up your facility, as you're setting up your program, health program or health project. Then we have what is called organizing tools. Organizing tools, just like they're called, they help you to organize yourself financially. You need to know what the Constitution says in terms of health financing, how I can receive money, what I can charge for, etc. For instance, the Kenyan Constitution clearly states that anybody that comes to your facility for an emergency, You can't ask for money before giving the emergency service. You have to give that emergency service. So as you're planning, you need to keep aside money and realize that there are some emergency services you'll provide that somebody will not pay for. So what does the Constitution say about healthcare services, about paying for them? It's important to know, have organizational charts, things like what we call a balanced scorecard, to show how you as an organization are going to create or generate value, and the value that people are going to get from your facility, from your hospital, for your clinic. So such things help you to visualize and organize yourself financially. Have different flow diagrams. There are different flow diagrams, like we talked about a cash flow statement. You can have a cash flow diagram that shows how money comes in and how money goes out. Clear job descriptions, because remember, another part, something else that you use for your money is, one, payment for human resources, and two, also the human resource in charge of managing money within their facility. What is their job description? There's someone who might be collecting money. What is their job description and the scope of their work? There's someone who is allocating and directing that money. For example, the hospital administrator. What is his job description and what is the extent and scope of his work? Can he sign checks, etc.? Chart of accounts, expenditure codes. I think some of you, when you're doing budgets, you hear about budget line item, and then that budget line item has a code. For example, ICT services is 113. So whenever you're asking for money, you need to use that code and such things. Finance manuals, those could be country manuals, specific organization manuals, specific manuals for your hospital. Finance regulations, both international and national. And then now budgets. Then how do I control money in my facility, in my clinic, within my program? It's important to have a board of directors to maintain transparency and accountability, so that you don't have all the financial decisions being made by one person, the checks being signed by one person. Nobody knows why they're signing checks, why they're doing whatever they're doing with the money in the facility. The board of directors is an important control point for finances and for financial management. So it's important that every facility has one. And I think especially in the public health system, based on the FIF Facility Improvement Fund regulations, those are funds that come from DANIDA and other donors, they insist there has to be a committee or a facility board that is made up of community members. So that is also a form of internal control. And in that committee, you find that there's a financial committee that monitors and controls what happens with the finances within the facility to maintain accountability. Budgets, delegated authority, like I mentioned, being an AIE holder, authority to incur expenditure. That means I have the authority to sign checks and say money can be spent or not spent. Procurement procedures are very important, so that you know when we decide to buy something, how do we go about it? Because that usually brings a lot of problems, a lot of issues, and you find yourself in front of the Ethics and Anti-Corruption Committee answering questions you should not be answering in the first place. So you have to ensure within your facility, within your board, within your committee, within your health management team, procurement procedures are clear to you and also to your team. Reconciliation of spending. You always hear whenever auditors are coming, reconciliation. That means you check all the books, where money was coming in, plus the checkbook, plus other reports. They need to be aligned and reconciled into one document. Internal and external audits are important. External audits is when another person comes to check your books. Internal audit, you check your books yourself. So you have to have an audit committee as well that will be doing this for you. And remember, they audit both how you're spending your money, and they also audit the services, the quality of the services, and the effectiveness of those services, so that you can see whatever we are paying for or providing within the facility, is it cost effective and such like things. There's a fixed assets register. Now this register, you have to have it because it now caters for things like the land the facility is on, the buildings that you have, the machines that you have. Those are now the fixed assets. Then vehicle policy, how the vehicle is used, how it is fueled, vehicle work tickets, etc. all go under vehicle policy, and then insurance for your fixed assets as well as non-fixed assets. How do we monitor financial management? Evaluation reports, budget monitoring reports, cash flow reports, financial statements, project reports, donor reports, and audit reports. So these are important reports that you have to have at the end of every year. Make sure services that you're being given, things you have bought, things you're doing within the facility, within the system, they have been evaluated and a report written. Your budgets have been evaluated in terms of effectiveness and efficiency. Your cash flow reports have been evaluated in terms of how money is coming in, how money is going out. Financial statements, those are things like the income statement, profit and loss statements and such. Make sure at the end of each year you have them. Accountants usually know how to prepare them. I won't go into details. Project reports, all the projects you have in your facility. If you are building something, if there's a service you started, for example, you're saying we are doing a one-stop shop for cervical cancer screening and treatment, and we spend this much money. So you have to have a report at the end of the day of how that project went. Donor reports, because donors always produce reports for what they're doing in terms of funding. That's why you see someone like the World Bank producing reports. You need to be able to read those reports, have them with you, and those reports will help you monitor how you are managing finances within your facility, within your clinic. Audit reports, both internal and external. I'm seeing someone has raised their hand. Let me take that question before I go on. Rose, please go ahead.
I think it remained there. Thank you.
Oh, sorry. Yeah, I thought you had raised your hand. So let me just give me a minute to set French interpretation. Interpreter stepped out for a minute, so let me just set interpretation. Give me a moment. Alex, do you have are you on the interpretation platform? Yeah, set it up. Okay, let's go on then. So this is monitoring tools for financial management. So this, I'm just giving you the tools that you need as a manager at a facility. What do I need to ensure that financial management goes smoothly? Because in terms of doing the nitty-gritties, the financial statements, the reports, etc., someone else who is equipped for that will be doing it, either the hospital administrator or the accountants or auditors. Next, last but not least, something I thought would be important to mention is the National Health Account. So the National Health Account is a systematic and comprehensive and consistent monitoring of resource flows in a country health system for a given period. So we might say we are monitoring the National Health Account between 2021 and 2025. So what will we be looking for? We will be looking for who in the country is financing health services. So is it private? Is it public? Is it donors? Is it people themselves through out-of-pocket expenditure? So that is what we look at for the next 5 years. Then how much do they spend? And then on which services? And then finally, who benefits from these expenditures? So National Health Account is very important to assist us in making policies that are effective in terms of providing the much needed services to the communities and to the population, and also to improve health system performance, such that we are not paying for services people don't need. We don't have people going into catastrophic health expenditure because of health expenses. Then in case we have donors pulling out or grants drying up, etc., we will also know if we are doing a National Health Accounts Survey. So I would like to challenge you to go and look at whether your country has been producing a national health accounts reports. It will really help you understand better how your country is financing, if your health system performance is efficient and effective or not, and what gaps you have in terms of health financing and financial management within your country. I am now going to stop there and take any questions or comments. Or if anyone wants to share their experience on how they find themselves answering questions in front of an ethics and anti-corruption committee for anything they did not do. Go ahead, Rael.
Thank you very much. I got lost the first time, but it's not related to what I'm going to ask. I joined this, this is my first time to join this training, and I've discovered that you have already covered 6 modules, and I wish to enroll in the other 6 modules so that I get the certificate, because this information is so crucial to me and my work environment. So how do I get enrolled in this, in the other 6? Thank you.
Thank you so much for that question. So for anybody who has not enrolled for the 2022 cohort, you will have to wait and enroll with the 2023 cohort. Reason being, this is a very intensive course. Those who have gone through it will tell you there's a lot of information and a lot of concepts to understand and capture. So it's not something that you can go through between now and December. So the best thing would be to wait. You can continue joining our meetings and as you listen and also as you learn, because the discussions could be different from what we will be having next year. So please wait until 2023. We will give out a call. Just register on afrophc.org. I'll put the link in the chat. And then so that you can join our mailing list, then we will put out a call in January for 2023 cohort, and then you can join as well.
Thank you, thank you.
And for anyone else who would like to join, you'll have to wait for the 2023 cohort. So I hope this has been helpful and has been a helpful discussion. I'm going to call out again if anyone has any comments, has any questions, has any experiences they'd like to share. Please feel free to do so. And remember, there's no right or wrong answer, and no question is too small or too trivial. We are all learning from each other and supporting each other as colleagues as we try to build a primary healthcare system in Africa that is strong and is sustainable. And as we try to build ourselves up to either be better managers if we're managing right now, or to be managers in the near future. Anybody else?
Hello?
Yes, go ahead.
I wanted to share this experience in Kenya, where since devolution, where we have since 2013, when devolution came in, there was an outbreak of our politicians building some structures. I cannot call them health facilities. They could build a structure with one room, then they call it a dispensary. Not, they were not following norms and standards. So when you go and inspect that, I'm a public health officer by profession, we always go and inspect, and when you are called to inspect, sometimes you get dumbfounded that how do I now inspect this small room? And yet the standards which I have, norms and standard, for a dispensary, a minimum of at least 7 to 10 rooms to take care of all those sections. So this is what this is the experience I wanted. We have a lot of buildings, structures without health staff, but when politicians stand there and do their campaigns, they will just say, I've built a health center there and there, but yet they're empty. So thank you.
Thank you so much, Rael, for that comment, because I think like we were discussing earlier on the issue of Rwanda and Mungabo being flabbergasted. We mentioned the issue of leadership and good governance and accountability. So the question you should ask yourself is, after devolution, or even before devolution, what kind of accountability structures were there to ensure that people do what they're supposed to do? And right now, do those accountability structures still exist? Because you have to understand that politicians will be politicians, and a lot of them, if they do not have integrity, and if there's no accountability structure for them, then they will do what would gain them popularity, because being a politician is about popularity and populist things and views. So the question is, are there accountability structures? Because building of those facilities is part of healthcare spending. So is this good stewardship? Are there accountability structures? And in terms of efficiency and effectiveness and what the population needs, did the population need that healthcare facility, or did they need something else? So those are some of the things you can ask yourself and also analyze and see where the gaps are. I have seen another raised hand. Harry?
Yes, good afternoon.
Good afternoon, go ahead.
Yes, thank you very much for all the presentations. I'm more interested in this national health account because in Sierra Leone, they are just assessing all of the NGOs and other partners that are receiving donor funds related to health. And now they are documenting that process. Well, normally what happens in our country, for instance, we are implementing for the Global Fund. Some of these resources are normally unspent. And when they are being unspent, we normally understand that these monies are they are not only being reprogrammed, but at the end of the grant year, this money is returned back to the donor. Whilst there are several needs that are still need to be addressed, even from the year 1 of the budget, year 2 of the budget, then in year 3, if we do not achieve all of those activities in year 1 and year 2, then the funds go back to the donor. So it's a little bit shocking to me to see that funds are being returned to donors when we highly need it. And how do we account for some of these funds that are being returned to donor? Are they captured within the national health account in terms of resources that are being returned to donor, and then get a comprehensive report on that so that we can get a sufficient accountability process of funds that are being unspent in terms of resources that are being delivered to countries? So that's my own question I'm trying to ask. Thank you.
Thank you so much, Harry, for that question and comment, because it's an important one. And like you remember when I was starting out, let me just share my presentation again and show you that Rubik's Cube. You can see this man on the left and him trying to figure out how he's going to position this cube to get what he wants. So there are two things there. There's one, the problem and the burden of vertical programs, donor programs in Africa. That is a huge, huge problem. Because if I come and tell you I am giving you 50 million, for example, dollars to go into HIV or cervical cancer or something, and the burden of disease that requires those funds to be spent within that period is not enough, or you don't have existing structures to ensure, or a plan to ensure that it is used effectively, then that's a problem. And donor funds usually come with caveats. They tell you what we are going to fund is maybe drugs alone. We're only going to fund drugs and maybe HRH and something else. but we are not going to touch facility construction, for instance. You needed to construct a facility because that place probably does not have one, but the donor told you you cannot. So you have to find a way of utilizing those funds within the constraints and the contractual obligations that the donor has given you. So that is one, the burden of vertical donor-funded programs on Africa. Because as much as the government would like to use that money on other things, they cannot. And yes, the National Health Account usually captures this data. You can just go and Google, and they usually publicly accessible documents. Google the one for your country and you will see it will tell you, we had to return this amount. That's why donor reports is important in financial management, because it will show you the amount that was returned and then why. Because a report comes with the why, not just the numbers. It says why this amount was returned and why it was returned and such things. So now it calls to us to decide, in terms of financing, how much do we want to depend on donor funds? Because now that is unfortunately a burden that a lot of African countries have to carry, that inefficiency in healthcare financing and spending because of donor contractual obligations. I hope I've answered your question, Harry.
Thank you very much for your response. And you are actually highlighting some issues, especially from this of your picture. I'm seeing universal health coverage, health financing. But if you see primary healthcare systems, it's not well properly coordinated. It's not properly decentralized. And people are there who do manage the resources to support the primary healthcare. Definitely, the universal health coverage will be a challenge to achieve. And then health financing will still be a challenge. For instance, health financing for poorer people. For us to have an health insurance scheme, we are yet in the process of really establishing that by government. And a building has been rented, the structure is there, but there is nobody in the building. And they are talking about health financing, health insurance. And these are all aspects of health financing to make sure that poorer people can afford health services whenever they are being challenged. And these are all processes that lead to strong primary healthcare systems that will lead us to achieve the universal health coverage. But even up to now, the systems are so weak in some countries. Some countries have gone really far, but in countries like the West African countries, we are still finding a big road in order for us to achieve the universal health coverage. So in terms of resources that we give back to donors, why not negotiate with donors to see how those resources that are being returned strengthen up the primary healthcare as means of financing them to ensure that we actually move towards achieving the universal health coverage. So these are some of my concerns. Really, I see working with donors is actually nice, but at times we don't have resources as an African, as poorer countries or low resource countries to finance our healthcare systems. So it's a big challenge. And how do we gamble between those resources that are being returned to donors are still the gaps that we need to address within the health financing system or within the healthcare systems, not only the health financing, gaps that we need to still address within the health systems. And if we don't address those systems, the health systems will still be weakened. And whenever any pandemic break out, then we are still left exposed to disaster. So these are some of my concerns. I don't know how the Afro PhD can really look into this and bring out some salient reconciliation in donor resources that are being returned in terms of the gaps that are being still existing within the healthcare systems. Thank you very much. Over.
Thank you so much, Harry. And as we close, because our time is up, I will say this: one, beggars are not choosers. Donor money is not a loan. You cannot decide where it goes and you cannot renegotiate. That's the thing. So the question is, do you want to continue relying on donor funding, or do you want to try and create your own sources of funding? That is one question. The second question is for countries which are low income. Really, you have no choice but depend on donor funding. Can you have negotiating structures and power as to where the funding goes? That is one. Can you lobby, advocate for, and look for donors and funding that goes to the area that you need it to go? That's another question. 3, in terms of governance, political stability, economic sustainability, how are you doing as a country? Those are other questions, because if leadership and governance is not well structured, it's not handled. If issues of economic stability and how people make money, how people survive in terms of how they get food, where they work, etc., is not handled, then the health system will remain weak. So looking at it holistically is the whole point of a primary healthcare kind of system and a biopsychosocial kind of approach, where you don't look just at numbers and how they come in and how they go out, but you look at the system as a whole. You look at the community as a whole. You look at the sectors that intersect with the healthcare sector as a whole. Because if you look at your individual countries, you will notice there are other things other than healthcare that is wrong. It could be the political angle. It could be lack of leadership. It could be lack of capacity building. It could be so many other things that are making it difficult for the healthcare system to exist within such an environment, or to exist within other weakened systems and structures. And as Afro PHC, you know, we are developing a policy framework for primary healthcare in Africa. Please go to our website, interact with that document. There's a direct link and you can put your comments there. We are doing capacity building for primary healthcare workers in terms of leadership, management, and governance, such as this. We are capacity building in terms of research, even how to write grant proposals, etc. So Afro PHC is doing its part. Join Afro PHC as well. Do your part, build your capacity, contribute, and hopefully we will make better primary healthcare systems for Africa. With that, I would like to thank you all for continuing to join. It is you who make this discussion rich, and it is your experiences and your sharing that make it rich. I look forward to seeing you next month as we tackle our next module, which will be on, I think it should be on HRH. For those who are continuing with the modules, please continue and try to finish by December so that we can all graduate in January. For those who need to enroll, you can enroll in January for cohort 2023. Have a lovely evening, and thank you so much, everybody.
Yes, thank you very much for all the presentations. Have a nice day.
Thank you.
Thank you, everybody. Bye-bye.